It's important that we realize decision-making in medicine is not just in the hands of the provider. In many cases, it can feel that way when we're working with patients that don't have the ability to make their own decisions or are not conscious enough to tell us their wishes. But we still travel through that area with caution. And if we're doing something for someone else and assuming for them without their input, we run the risk of using them to meet our own ends. Patients have the right of autonomy in our society. Autonomy is the ability of the person to make their own decisions and decide for themselves what they would like as the outcome of their medical care. Now, whenever possible, we should inform patients of what's going on and allow them to make decisions based on that information without undue influence from the providers. And a lot of times, that's not actually what happens. Now think about the patient that you respond to after the end of a 48-hour shift that you've been on and run calls over and over again. And this patient has a complaint that you don't feel is particularly important. And you're a little burned out and tired and short-fused. Say that it's appropriate perhaps for that patient to seek care by non-emergency transport. Yet we talk them into doing that when they don't want to. It may be that we're choosing for that patient and not allowing them by influencing them with words like, well, your insurance won't cover this transport. Or if we transport you, you won't get into the hospital any faster. Now, it's important to tell patients some of these things, but not as a means of having them do what we want them to do. Rather, we should be informing patients of these things and asking them with that information, what would they like? Leaving a patient at home with a signed refusal can be unethical and legally risky. When we're talking about autonomy, patients that don't have the ability to make that decision, we then will use ethical principles to guide the decision-making process in absence of their input. Non-Maleficence. Non-Maleficence is essentially making sure that we minimize the risk that our patients are going through when we care for them. It falls along the idea of first, do no harm. We want to minimize risk that's associated with our treatment and always go for beneficence, in which we're trying to make sure we maximizes the benefit to the patient. So minimize risk, maximize benefit. And then finally, justice. And justice gets a little tricky when we're dealing with things like MCI. I encourage you to look through your textbook, your local protocols and local systems, as well as the PHTLS 9th edition book for discussions on multiple casualty incidents. Justice is essentially outlining what's fair. And when we're talking about justice, in those cases like an MCI, that justice involves, is it fair to give this person care and not this person care? And so assignment of limited resources in excessive need can put us at risk of violating individual justice. Thankfully, though, there are frameworks that allow us to make good decisions and ethical decisions in these situations, but they do require some forethought before you experience the incident.